Good afternoon. It's been a pleasure to be a part of this second breast innovation course. I'd like to thank the organizing committee for inviting me to present a good friend of mine who've been working with for more than 15 years, and Dr. Vasilis Katsaros, who is an MR specialist, very keen on advanced MR techniques. He's working as a senior consultant radiologist and neuroradiologist and director at the MRI department of the General Anti-Cancer and Oncological Hospital of Athens. And he's head of the uroradiology in Central Clinic of Athens, clinical research affiliate in the Department of Neurosurgery of National and Kapodistrian University of Athens, Greece. And for many years, more than 25, he's been applying advanced MRI techniques, not only on brain, which is his main field, but on other aspects such as prostate and breast MRI. So he's going to give us a talk now on breast MRI imaging, diffusion and permeability with ultra-fast DCE. Shortly after his talk, Dr. Evangelia Panouria, who is a radiologist at the First Department of Radiology, University of Athens Medical School, RADIOLOGY Hospital, and Dr. Lukia Poulou, MR and CT consultant radiologist at ESO Maternity Hospital, are going to comment on his talk and give us a good interaction on Vasilis' speech. And I'm really waiting for that. Hopefully, he's going to enlighten all this tricky physics performing in order to get the right information on ultra-fast DCE and the techniques involving these methods. The floor is yours, Vasilis.
Okay, good afternoon also from me. Thank you very much, Denise Kolomodi. We are really working for a long time together, and I want to thank the organizing committee and especially Dr. Nikos Dimitropoulos for inviting me, although it's not my first field, but I'm trying to do whatever we can about advanced imaging in breast MRI, and if possible to help to evolve artificial intelligence in MRI of breast. So I think you hear me.
Everything is fine.
Okay. I think I have to
share your screen.
Share screen. So as you heard before, the issue that I will discuss and try to cover in this lecture is the diffusion and permeability with ultrafast DCE by breast MRI imaging. My outline will be based on multiparametric breast MRI, a bit longer discussion about diffusion techniques and methods, and also about ultrafast dynamic contrast enhanced permeability technique. I like the permeability because the permeability term, because it describes more some things that we will discuss together, and then the indication and clinical application of HF1 method. So, according to the state of the art breast MRI, an article which was published in 2019 in Radiology, the multiparametric breast MRI should include at least T2 weighted images of high resolution, diffusion weighted images, T1 before intravenous contrast administration, ultra-fast dynamic contrast enhanced permeability MRI, as well as delayed images of T1 after gadolinium administration. So in our department, we are performing, except all these, another sequence, very high resolution STEER, short time inversion recovery. So this is a fat saturation technique, and also the restricted spectrum imaging, which is a part of diffusion imaging of our department. And all these in about 15 to 90 minutes, depending on how large the breast of the patient we are examining is. So about the diffusion techniques, first of all, diffusion weighted imaging, which is I think I have to make diffusion weighted imaging. What is really diffusion weighted imaging? What are we doing with diffusion weighted imaging? All these techniques are not only these that I'm referring in this talk are considered as functional techniques. We have morphological, structural, anatomical techniques, and all these that you see here: diffusion weighted imaging, restricted spectrum imaging, diffusion kurtosis, intravoxel incoherent motion, maybe diffusion tensor imaging, and tractography are considered, although not really, as functional techniques. So on what physical scheme we are based to make these pictures, diffusion imaging? The molecules inside our body undergo random translational motion, which is called Brownian motion, and this is what we call diffusion. There are, as you see here, motions in the space in not a resonant way, and the main molecule that we are examining by the MRI is the water, and mainly the proton of the hydrogens. So the molecules probe the tissues at a microscopic scale. So what we are aiming to do is to measure these molecules and these Brownian motions, which we are doing with a technique that is called diffusion imaging, and we can pulse gradients, peak and echo sequences, 90 and 180 pulses. So put the gradient and not put the gradient, and the P factor controls the diffusion weighting, and it depends on different aspects of MRI techniques, which I don't think you'd like to hear in these lectures. So there are diffusion, and the diffusion imaging, we have free diffusion as cysts or lesions that containing really water, so the spins acquire random phases and the phases cancelled, so we have signal loss. And when we have restriction of diffusion, or a better term, hindered diffusion, because of cellular membranes, architecture, protein shields, we have low signal loss. This is what we are measuring. One acquisition without diffusion gradients we acquire first, and then in the simple diffusion sequence we acquire three different sets of images with B value of 50 seconds per quadrat millimeter, 400 and 800 accordingly, applied along three perpendicular directions. And then by this formula we can calculate the apparent diffusion coefficient. So this is an example in a patient, 45-year-old patient, where we can see the high signal intensity in B value 800, and with this formula we can calculate and can see that we have an ADC value of 0.6892 millimeter, which is considered as restriction of diffusion. What is the other techniques that we are the other technique that we are using routinely is the restricted spectrum imaging, which reflects the signal from cells with higher nuclear to cytoplasm ratio without gadolinium-based contrast. We can have a distinct mathematical behavior of water diffusion in separable microscopic tissue compartments, so we can detect the microarchitecture with high conspicuity and highlight the key aspects of the tissue. So this is the scheme that we are using. You can see different distances and different values of tissues, and we can this detect and calculate. One acquisition again without diffusion gradients, and then 5 acquisition with diffusion gradients and B values of 0, 50, 600, 1200 and 1800 seconds per quadrat millimeter applied along multiple directions. And then we can calculate not only the apparent diffusion coefficient, but also some other metrics as kurtosis and intravoxel incoherent motion in our post-processing. So here's an RSI paradigm of a 41-year-old patient with a high-grade triple-negative invasive ductal carcinoma. This is the T2 image, and this is the B1800 image, which we can fuse in this image and see much more better than in the B1000 or B800, the restriction of diffusion in this carcinoma. And this was the histological on the bottom right, the histological confirmation. What is diffusion kurtosis? We perform a non-Gaussian fitting. We need these high B values, so we don't have any preferential diffusion direction, and we perform isotropic diffusion, and we can calculate the kurtosis index. So in this case, as you can see in color, this region that has low ADC has high kurtosis, which is considered by all the literature and all publications as more sensitive and specific marker for a malignant lesion. What is intravoxel incoherent motion? It is the denoting of microscopic translational motions that occur in each image voxel in MRI. In biological tissues, these motions include molecular diffusion of water, microcirculation of blood in the capillary network, also called microperfusion. We consider them as an incoherent motion since the capillary cellular organization can be seen at the voxel size as random. In this case, we need at least 2 or 3 B values from 0 to 500, 400, and the best technique is to acquire every 10 to 15, so 0, 15, 13, 45, 60, and so on. So we can calculate not only the molecular diffusion restriction and the tissue perfusion called D star, but also the vascular volume fraction. So you can see here in this diagram that normally we have 0, we have 400 and 800. You see how many B values we are acquiring here in this region between 0 and 100 or 200, and then we can perform the other B values also. What has this as a result? So we can see the microcirculation in this. This is the F standard marker, and in this case we see that we have peripheral increased microcirculation, and this is the diffusion kurtosis that I showed you before. That was more sensitive and specific for this carcinoma. And in one picture we can see all these parameters. So we can see ADC, we can see K up, we can see D up, we can see the diffusion weighted imaging, the IVIM-F, the microcirculation, as well as the diffusion. What about the consensus and mission about the diffusion weighted imaging of the breast? So there is a very nice article, very nice paper by the USOBI, the National Breast Diffusion Weighted Imaging Working Group, leading by Pascal Balzer and Denis Lebien. And this, I will show you how the problems are with diffusion. So when we have high B value and low ADC in this very nice picture, then this is probably a malignant tissue. When we have high B value and benign and high ADC, this is called T2 shine through phenomenon, in which the diffusion calculation is adjusted, is more on the T, is based more on the T2 weighted signal, and so this is dominant to ADC and diffusion values, so we have high ADC. And the other phenomenon that is of importance is the blackout effect. So you see here malignant tissue, fibrotic parenchyma, scars, or low cellular cancer with extensive desmoplastic stromal fibrosis with low diffusion in high B value, as well as low ADC. This is a false negative picture. And here you can see a benign tissue again with a false positive imaging with low signal in the high B value and low signal in ADC. What about the ADC thresholds and value ranges? This is from this paper. So it is, as you can see from the top to the bottom, we have for different malignant breast from benign lesions. So this is under 0.8, very low for most probable malignant lesion. Low, this is indeterminate between 0.8 and 1.2. So if we have a lesion that exceeds in ADC value 1.6, we are most probable that it is a benign lesion. And here is the imaging reconstruction of all these, what I said before. So we have here ADC of 0.8 in IDC grade 3 breast cancer. You can see the high signal in the left breast as well as the low ADC. 0.84, it was very low, so this is again a carcinoma of the breast. And here we're going up to 1.8. That's why the threshold is originally 121, because if you see here, we have a 158 for a fibroadenoma and 182 for infection, and for a high inflamed cyst is a very high ADC value. What are the clinical applications of diffusion imaging? It can be a part, as I showed before, of any multiparametric breast MRI, independent of the clinical indication for MRI, as it improves the characterization of lesions detected by contrast-enhanced MRI, irrespective of the indication. There is not yet evidence to recommend for or against the inclusion of diffusion imaging in screening protocols. It can be a very valuable alternative option in patients with contraindications to gadolinium-based contrast agents. And here you can see how we can discriminate by diffusion-weighted imaging the high signal intensity in high B value, where we have to do with malignant lesions, while on the right breast, while in the left breast we have to do with a fibroadenoma, which is resolving here in the high B value. What are the clinical applications of diffusion imaging? We can better detect and evaluate quantitatively the lymph nodes, and also we can have a marker of prognosis of response to neoadjuvant treatment in breast cancer patients by ADC. Here is an example of a lymph node which we have seen in a relapse of a breast carcinoma after 12 years in a 75-year-old lady. So we see here that the mean is 0.68, and this is sure that we have to do with a malignant lymph node here. And what else we can do by our machine in our department, which we are introduced from July 2020, is the diffusion imaging with background suppression and make a whole body like a PET-CT. So we have here a relapse of a breast carcinoma on the right side, and you can see all these lymph nodes in the axillary region, subclavicular, supraclavicular, as well as in the neck region. And if you look here better and closer, we can see also some metastases on the bones, as well as down in the lumbar spine. We can also use diffusion imaging to accelerate biopsies or marker and hook placement. Here is a paradigm in which we had a granuloma with restricted diffusion because we didn't have water inside of that, so we can measure something that doesn't have water, and it shows a hindered or restricted diffusion. And another lesion in which we had cancer in this lumpectomy, which we have scanned before, pre-operatively and post-operatively, and we see that these regions are excised. although there is a very attractive technique, in diffusion imaging there are some caveats. So we have to think about distortion effects, eddy currents, lower resolution to morphological anatomical imaging, and what we said also before by this scheme, the T2 shine through and T2 blackout artifact. And of course, this technique should not exceed more than 4 minutes. In our department, we are performing this in 3 minutes and 30 seconds, so that we don't have motion artifacts. What about DCE? So this is the classical DCE method in which we are using contrast gadolinium administration, and there are conventional and abbreviated protocols in which we can evaluate the kinetic curve and see the first initial slope, which can be fast, medium, or slow, and the delay after about 1.5 to 2 minutes if it's a persistent plateau and washout. And this can characterize or can show us the probability of a lesion to be benign or malignant. But what is the disadvantage of this method and these curves? It's still qualitative, so it's still subjective. So we are doing abbreviated or even more ultra-fast dynamic contrast enhanced permeability imaging, in which we need high quality data, which means that we have to acquire all these techniques with high high field magnets. Sorry, this means the hardware and also some other things that has to do with slope, slew rate, and so on, and also software. And so we achieve 2 to 8 second temporal resolution, and we can acquire more dynamics over 60, so that we're more than 2 or 4 minutes in the counting. What is this? What is the advantage of ultrafast DCE? That in some cancers we can see even in 4 to 8 seconds or 12 seconds. In the first 15 seconds, this is a case with the breast cancer on the left side and also here, and even before the vessels are enhanced, the tumors which are washing out. So you see here on the top that we have 4 seconds and 8 seconds in enhancement, and deletion of enhancement after 4 or 8 seconds. That is the biggest advantage of this technique. So this is the same case in 8 seconds. This case has a vivid enhancement of this lesion, which confirms that we have to do with breast cancer. What else we can do with abbreviated and ultra-fast and even conventional dynamic contrast enhanced or permeability study is to evaluate other markers, which to my opinion is a very good thing. So we can see here not only the image of this case, but the quantitative, semi-quantitative wash in and wash out. So we have here, it begins to come into the aorta, and in 3 or 4 dynamics, that means in 4, 8, and 12 seconds we have the peak of this lesion, and in 60 seconds we can see the wash out. So I can go further on that. At least to my experience from breast MRI and from different papers in the literature, what is very helpful is the area under the curve, which still it's semi-quantitative. What are the disadvantages of ultrafast DC MRI? Of course, we have a very high temporal resolution, but we can't have the same temporal spatial resolution as we have in conventional or even abbreviated DCE. As you can see here, we can go not further down from 1.5, 1.53 millimeter voxel instead of 0.8, 0.8, 1.6, and so on. There is a very evolving feature in this ultra-fast imaging the last 5-6 years. So here are some disadvantages of the low spatial resolution and maybe a false positive. This is a fat necrosis in this case. And also you can compare the resolution, the spatial resolution of the conventional dynamic contrast enhanced and the ultra-fast DCE. So there are evolving things that should be done. There is the compressed technique that can further decreases the acquisition time, and so we can also increase the spatial resolution. The other disadvantage of ultrafast DCE MRI is the loss of sensitivity, according to many studies, and this is because in some low-grade in situ cancers or lobular cancers there is delayed enhancement. And also there are benign vascular or inflammatory breast lesions as papillary lesions reflecting highly vascular nature of these tumors, capillary hemangiomas, intramammary lymph nodes, and fibrin adenomas that can possibly enhance very fast. What are the clinical indications of ultrafast DCE? For this time, it's in research mode, so for clinical indications and especially for screening, there are no recommendations for performing this ultrafast DCE, but only in the context of a multiparametric breast MRI with also delayed imaging. Let's go, what else can we do with ultrafast DCE? So we can, that's why I'm referring to this technique as permeability imaging. We can measure how much contrast or gadolinium has exchanged between plasma capillary bed and interstitium. This is not one way side, so we have two ways. So the gadolinium goes out to the interstitium and then goes in onto the plasma capillary bed. So we have compartment modeling, pharmacokinetic models, which I don't want to go further, which needs the high quality data that I referred for before. So we don't have to be more than 4 to 5 seconds temporal resolution. So the simplified model that we are using is the extended Tufts model, which correlates the best with histology according to the literature and also to our experience. So this is to remember a bit about neuroradiology, how we can evaluate and see all these measures and have quantification of these parameters. So you can see here the K-trans, which is more than 0.1, which is considered as the threshold between malignant and benign and malignant tumor. If you see the fitting of the curve, you would see in this case, which by biopsy was a mixed tumor, an infiltrative intraductal carcinoma with an acina carcinoma, that we have a curve type 1. So if we don't have these 4-5 dynamics with 4 seconds each, we could lose this tumor even we have the ADC very low. So this is a quantitative objective method in contrast to qualitative and semi-quantitative methods I referred before, which is the first step. We need many, many steps to go to artificial intelligence and then by MR mammography to individualized precision medicine. So the diagnostic performance in the study, which was published in October 2020 in Radiology, which is using the only software which has FDA approval as artificial intelligence / shows that we have an area under the curve of 71 for 0.71 to 0.76 with sensitivity for BIRADS 3 category higher from 90 to 94%, but not when using BIRADS category 4A. Specificities showed really no differences. And another paper that is published last month in Seminars of Radiology from Massachusetts General Hospital shows that this particular software could help radiologists and reduce classification errors, benign versus malignant, but lesions must first identified by the radiologist to make use of the AI system. So an additional drawback of this study of 2020, which I showed before, is that the radiologist's behavior in a radio study may not reflect the behavior that we have in everyday clinical practice. So the take-home messages from this talk is that diffusion imaging and ultrafast DCE permeability may add valuable and quantitative information to the screening as well as the pre-therapeutic workup of breast tumor patients. Especially diffusion proves to be of utmost importance in cases with contraindications to gadolinium-enhanced studies, and each of these techniques has its limits and sources of error. The future may bring, first of all, standardization and improved imaging methods for individualized precision medicine, lesion studies that can correlate with MR-guided biopsies or even guide MR-guided biopsies, reference material and guidelines for interpretation, and new applications, and especially artificial intelligence. Thank you very much for your attention.
Thank you, Vasilis, for this comprehensive talk, which enlightened the role, restrictions, and potential of diffusion technique as an additional tool of breast MRI, as well as the application of DCE technique and the future of AI. We are running short of time, so I'll be delighted to hear a short comment from Panouria Evangelia, either Lucia Poulou, whoever would like to comment on Vasilis' talk. Thank you.
Good afternoon. I actually want to thank Dr. Katsaros because it was an excellent talk on a very complex subject. I think an important takeaway message from this is that diffusion weighted imaging does add value, but it is not an alternative to contrast-enhanced MRI in problem solving or screening. One question for Dr. Katsaros, I would like to ask, what ROI method do you use for your lesion? Do you include the whole lesion, or do you take the lesion with the lowest ADC?
Well, if we can include all the lesions, I mean, it's first of all, the first thing that we are doing is inspecting that by qualitatively. So if the lesion is very big, then it has a very big part of restricted diffusion, then we can include more pixels. At least the last suggestion from this paper from Balzer and all is that we should have at least 3 pixels of the lesions. So if you design a ROI, you should design it in the lowest ADC and to have to include at least 3 pixels of it.
Do you find it's helpful in all malignant lesions? Because I find it doesn't do very well in non-mass enhancements, just solid lesions.
So it adds, and if we don't have the T2 blackout effect or the T2 shine through, it can guide us sometimes to have the to design the curves in the lesions.
Thank you very much.
I thank you for your questions. They were very interesting questions.
Could I comment, please? Add a little comment for this presentation. Thank you very much for the invitation. I understand, Dr. Katsaros, that nowadays there is a trend towards to put all the knowledge that we have in neuroradiology in breast MRI imaging with new techniques apart from diffusion imaging, DC perfusion, and there are other tries to put spectroscopy or techniques like T2 and T1 mapping in order to find a method not to use contrast media. and become MRI, as it is a very sensitive method, a method either for screening for breast cancer. That is all that I wanted to say. Thank you very much.
Yeah, if I can comment on that, Dionysia. So the trend in general is not the multiparametric. We don't have patients only with contraindications to gadolinium enhancement. We have also patients, we have also some studies the last 5-6 years that we have deposition of gadolinium in brain structures. So I've forgotten to say that, in this trend, the whole body, as far as I can follow everything, it's a trend to have a biparametric without gadolinium enhancement, and this can be helpful also for artificial intelligence.
Yes, to be more objective.
Yes, but it needs time. I'm not so sure that in the next 10 or 20 years we will have softwares that could really help us without automatically automated the detection of all these lesions. Thank you for your comments.
I'd like to thank you all for the comments, the conversation, and I'd like to pass the microphone to the next panelist, Dr. Savvidou Despina, Director of CT and MR Unit of Bioiatriki, Athens, Greece.
Hello to you all. Thank you, Dr. Kolomodi. Congratulations to the organizing committee for this high-level seminar. Our next presenter is Dr. Varaki Kalliopi. She's Director of Radiology Department at Metropolitan Hospital, Athens, Greece. She has performed subspecialty training in CT and MRI in Ohio State University Medical Center in USA after finishing the medical studies and radiology specialty in Greece. She's an expert in diagnostic and interventional breast MRI. The title of her presentation is MRI in Breast Presurgical Therapy, Monitoring Protocols, Response Prediction, and Response Evaluation. Please, Dr. Varaki, proceed to your presentation.
First of all, thank you very much for the invitation to be here with you today. I'll just share my screen and begin. Okay, can you hear me?
Yes.
Okay.
Yes.
So in today's talk, I will be discussing MRI in breast presurgical therapy, monitoring protocols, response, prediction, and evaluation. So I will focus mainly on where we are now, the routine clinical practice, and some future directions that are quite interesting since the course is focused on innovation. Now, just to remind you that chemotherapy, the rationale behind it, is based on 3 benefits: the ability to shrink the size of the tumor, so to convert mastectomy into breast-conserving therapy, to be able to operate inoperable tumors, and to improve the cosmetics of surgery and possibly downstage lymph node disease, as well as to be able to evaluate response to therapy in vivo during treatment, possibly change the regimen used, and also can be used as a prognostic marker. It mainly has effects on the angiogenesis, the vascularity, the cellularity of the tumor, and causes also extensive areas of fibrosis. That is why more aggressive tumors appear to be more chemosensitive. And it has been traditionally used in locally advanced inflammatory tumors, as well as early aggressive subtypes, molecular subtypes of tumor. After the completion of therapy, our gold standard would be the pathology report, in which, if there is a complete pathologic response, it will be designated as PCR, which means no invasive tumor. Some institutions also include DCIS, and of both breast and axilla in most institutions. If there is no PCR, we will be talking about residual cancer burden, RCB, which again, we are assessing both the tumor size, the cellularity, and the status of the lymph nodes. Now, what are our imaging goals? We want an imaging modality that can accurately stage before treatment, accurately provide us with the extent of disease, accurately restage, have a good correlation with the RCB and the PCR, and also be able to monitor if we are select to do this during treatment. Now, in practice, in clinical routine practice, by imaging, we're usually asked to aid in the surgical planning so that the surgeon can accurately measure viable residual tumor size and achieve a negative resection margin, also including the DCIS portion, or to aid the oncologist by assessing response to a specific regimen, if possible, early in the course of treatment, and measure changes in size of the invasive tumor. So any method, theoretically, that showed the abnormality in the beginning can be used to monitor. However, it has been well documented that MRI is the most accurate method for detecting tumor response and residual tumor. And this has been shown by various studies, the largest of which were the I-SPY study, the multicentric prospective I-SPY studies that showed that it had a very strong correlation for PCR detection and final pathologic size in comparison to other modalities. And also it had the best accuracy. This has been shown in various meta-analysis for PCR and RCB. It has been compared. This is the results of the Akron study. It can, by using measurement of longest diameter, it can be more accurate than both mammography and clinical examination. And it's also able to predict areas of fibrosis. It has been studied extensively in comparison to mammography and ultrasound in various meta-analysis and review studies, and has been found superior in accuracy. Now, with the MRI of the breast, we have an advantage in that we can simultaneously image we can view morphology and at the same time function. So we are only, for now at least, in clinical practice, looking at areas that enhance, and we are characterizing them morphologically. But at the same time, we are performing a dynamic study of breast tumor vascularity. We are following the contrast agent over time, as shown by the red dot, within a few minutes from the beginning to the end of contrast, showing its uptake and its washout, and giving us indirect qualitative information of the vessels of the tumor, and performing these nice color maps with red, the areas of washout, more indicative of higher grade tumors. Now, the last years, we have been integrating into our routine protocol faster sequences, ultra fast dynamic, and I think Dr. Casaros has sufficiently addressed the technical aspects. I just want to give you the practical ones of ultra fast dynamic contrast imaging. We're not looking at the passage of contrast within minutes, but what's happening the first seconds after contrast. And this is giving us additional information of highly aggressive infiltrating areas that will usually enhance very early, and malignancies have been shown to enhance approximately within 10 seconds after the arrival of contrast to vessels. And I'll show you this video. This is a large infiltrative tumor. You can see that it's enhancing almost simultaneously with the heart. It's very easy to integrate these into your protocol because they're very fast. They last only like less than a minute. And also, of course, by using multiparametric imaging and multiparametric approach to post-processing analysis, we gain more information from our sequences. And of course, in routine practice, almost every center now uses diffusion. It's fast, it's easy to acquire, it does not need contrast. And it's also quantitative, because with diffusion, we can, by using our marker of ADC, we can depict areas of increased or decreased cellularity. So malignancies will show a decreased diffusion, and usually in the range of 0.8 to 1.2, according to the literature. So by integrating these multiparametric techniques, we are able, and the largest study was a multicentric prospective trial, the Akron studies again, that showed us that diffusion is actually an excellent marker to predict PCR, both in mid and after treatment, but also is dependent on molecular subtype. So just a fast review of all the meta-analysis agree that by including these multiparametric sequences, such as diffusion, into our protocol, we're actually increasing the sensitivity, especially using diffusion, in comparison to just using the contrast-enhanced, the DCE images. So chemotherapy has specific effects on tumor, as we know. It affects the vascularity, the cellularity, and it causes fibrosis. So what of this information are we gaining the biology of tumor with MRI? Well, by using dynamic contrast enhanced sequences, either fast, ultra fast, or conventional, we're gaining information about the angiogenesis. By using diffusion techniques, more of the cellularity, and we are addressing non-enhancing main areas that mainly based on morphology, we can assess areas of fibrosis. So it's a very good modality to use. More advantages. We are producing 3D images in multiple planes. We have a very high spatial resolution. We can image images. We can image with our 3 Tesla scanners, small lesions, 2 or 3 millimeters, residual viable tumors. By integrating multiparametric sequences, as I said, we're gaining information of the biology of our tumor. And we use either qualitative, semi-quantitative, or quantitative measures nowadays, very in fashion, to produce imaging markers, again, addressing tumor biology. Now, its highest accuracy and correlation with the pathology report will be in a mass, as shown in this image, that shows concentric shrinkage. And this is the easiest to measure and the highest correlation with the pathology report. And usually it has the highest, it's been shown in the literature to have the highest correlation with pathology in more aggressive tumors. There are instances of underestimation. It can, in areas of non-mass, it will be less accurate. When the tumor shrinkage is non-concentric, which means when it's more of a crumbled sort of way, as we see here, this was a non-mass, and then we just had these scattered foci. It has been shown that these are actually scattered individual or stromal clusters of tumor cells in a desmoplastic stroma, and that's how it's reported in pathology. And it's very difficult to assess these areas, especially if they're just a few cells with MRI, and we will miss lesions here. And this is usually the case with DCIS, lobular carcinomas, and lower grade tumors. So subtype does play a role, as well as the type of treatment we're using. If it has a very strong anti-angiogenic effect, then it will cause less enhancement and it will be less depicted on the MRI. Overestimation can also occur, but it's mainly related to inflammatory granulation tissue that can mimic tumor, it can enhance, such as this case here, before and after. We see this residual area. We cannot give a complete response here. This was actually treatment effect. Be aware of necrotic tumors or mucinous tumors that have mild enhancement. We have to see no enhancement. If they're non-enhancing, this is probably areas of necrosis. And be aware of benign lesions, because this is a fibroadenoma and it disappeared post-treatment. So it doesn't mean that because it disappeared, it's malignant. And this is a case from our institution where we had this nice mass here, and the marker is shown here. It's advisable to place an MRI visible marker, because then we know where the biopsy was taken from, because our lesions can be multicentric, they can be multifocal, and MRI can detect more lesions than the other modalities. So here we know that this is the mass. It's very easy to measure the shrinkage of our mass. This would be designated a BRIC 6 area because the biopsy was taken from here. But the patient also had a non-mass area adjacent to our mass, depicted in the circle, and we would have to give a different scoring here. This would be designated BRIC 4. All this information has to be conveyed to the surgeon. And just to show you, the literature has proven that it's very good. MRI is a very good modality to assess our median correlation coefficient with pathologic tumor size. It's very good to assess size. However, we must always know the areas, its instances in which it will have a lower accuracy, molecular subtypes and chemotherapy regimen. MRI is also a very, very excellent examination to depict the axilla in multiple planes, as we see here. This is although ultrasound is still the mainstay for assessing the axilla, and this is because it's easy. You can perform a biopsy, an FNA, place a marker. It's much easier to perform this under US guidance. However, the morphologic information we're gaining from MR is also substantial. Here we see a normal appearing lymph node with its hilum and its very thin cortex. We can assess the increased short axis dimension. We can get information about the shape and the loss of the hilum. We can see enhancement beyond the borders of our lymph node, and we can suspect that there is extra nodal infiltration, and also we can measure the thickness of the cortex. And some advantages over ultrasound would be that we can also image the axilla bilaterally and have a comparison study. We can assess level 2 and level 3 nodes and internal mammary nodes and high-level nodes. And it's also less influenced by the amount of performer experience and irrespective of patient body habits. So, however, in after neoadjuvant treatment, it has shown to have a moderate sensitivity and specificity. So what can MRI give us? It can give us very good measurements of our tumor before and after, and it can also give us measurements of our lymph nodes before and after. And I would suggest whoever is using MRI to follow up neoadjuvant chemotherapy to use include in our field the lymph nodes, just increase your field of view a little bit to have all the lymph nodes included. So I don't want to get into all the details of the protocols. All I want to stress here is that the protocol must be very strict. We must follow the minimum requirements in order to perform. It's an extremely technical modality. If you do not perform it correctly, you will lose almost all of the information that you need. It's very important to be able to either in your own institution or another institution you're collaborating with, be able to perform MR-guided biopsies and localizations, because there will be MRI-only lesions. And sometimes even after neoadjuvant treatment, you will want to be able, the surgeon will ask you to localize these. The technical requirements have to be consistent over protocols. You have to repeat the examination with the same protocol. And here, as opposed to screening, we're not interested at least up to date in abbreviated fast imaging only. We're also very interested in delayed imaging. We need the images at 5 and 6 minutes, because the chemotherapy agent will reduce the enhancement, and residual tumor may enhance very late. Also, it's good to include diffusion, and by accordance to the USOBI guidelines would be good. I can refer you to their consensus of 2019. And how do we measure? It's recommended to use the RECIST criteria as we do with other body organs. We can also use volumetry, and it's very, very, very helpful in several instances that I'll show you. In any case, we have to adjust our volumetric data to the RECIST criteria. For example, if we have an increase in diameter of 20%, the volumetry would have a progressive disease with volume increase of 44%. So just adjust the differences and you can use volumetric. When do we say that something has completely responded to MRI? When we have absolutely no enhancement, even on the delayed images. So these are some examples. This is a poor responder before and after, and it's easy here because it was a mass to use our RECIST criteria of longest diameter. This, however, is a case of non-mass where it would be difficult to assess. It was very irregular. It's better to perform volumetry here, and especially after treatment. If we use diameter, we would be overestimating because there's normal breast tissue between these areas of enhancement. And so it's more accurate to measure the volume separately of the delayed enhancing areas. And this is a case of complete response where we have absolutely no enhancement on the delayed images. This is another case of our institute where we, just to show you before and after treatment, it's very important to assess, to register our images so that we know this small enhancement corresponded to the area of the tumor. And if we do this, then we see here that there is a residual enhancement on the delayed images. This is not a complete response. This is a good response. Another case, we have a biopsy-proven mass before treatment, a BRIC, a known fibroadenoma BRIC2, and a non-mass MRI only visible. Following treatment, we see the mass has shrunk, the fibroadenoma remained the same. What about the non-mass? Let's get back to that. So, before treatment, after treatment, very, very nicely depicted the shrinkage. We see our marker here. We know this is the area of biopsy. We can use volume studies or we can use diameter, whatever we want, and measure. We can include all of our nice diffusion, multiparametric measurements, and see that the diffusion has increased significantly. And there's a change in our kinetics, so we have less washout, less vascularity. Very nicely depicted. This is response. What about the non-mass? More difficult to assess. We saw that post-treatment, we had these residual foci of enhancement within the area of non-mass, far away from our initial mass. There was a normal and no enhancement in between anymore. What is this? This could be clusters of cells in desmoplastic stroma. This could be DCS. It could even be residual infiltrative tumor post-treatment change. Here is a case, I just wanted to show you that we could use MR-guided biopsy if the surgeon wants to localize or bracket our lesion or perform biopsy before surgery, if it would change the surgical planning. So always communicate this information with the surgeon. What does he want? How many MRIs should we be acquiring? We should have one baseline and one after treatment. And I cannot stress how important the baseline is. We have been receiving at our center numerous times just an MRI after treatment. We cannot adequately assess response if we don't have a baseline. It is critical. We cannot compare to mammography and ultrasound. We will have MRI-only findings. It is not comparing apples and oranges here. We use the same protocol, and it's good to place an MRI visible marker to know. What about if we want to also monitor during treatment? Optionally, we will have to acquire more MRIs early, usually following the first course of treatment, and in mid-treatment. And this can be used as prediction of PCR, prognostic survival outcomes, and also help the oncologist possibly change his regimen. And here, especially for monitoring, we can use advanced multiparametric imaging and post-processing techniques. Advanced measuring methods have been used in clinical trials. One of the most popular is functional tumor volume. For example, I showed you how to do diameter. We can use volumetry, but we can also use functional volumetric study. When we only select areas, we only measure the volume in areas that pass a certain threshold of enhancement. And this has been proven in the literature to correlate very well with certain clinical outcomes and PCR and RCB. However, it's not used clinically. It's more of an advanced research clinical trial protocol. Again, what about the use of multiparametric, more advanced, even more advanced? I think Dr. Katsaros did explicitly mention all of these. I will not get into technical details. They are not clinical practice up to now, but they have the potential of being able to assess response early before the size changes. That's their main advantage. Most of them are quantification techniques that address vascularity, permeability, vascular flow, and cellularity. This is a case from our institution, but we were just following this more for research purposes, where we performed quantitative permeability perfusion and measured our various parameters here. It was the changes were evident way before the shrinkage of the tumor. Other techniques, such as advanced diffusion techniques, I think Dr. Katsaros did get into this extensively, can be used for what we call parametric mapping. We can actually map every single section of our tumor now and gain information at what parts are viable, what parts are infiltrative. That's the goal, to have this tailored mapping of the tumor. Spectroscopy, even though DCE, perfusion, and spectroscopy have been used for decades in the central nervous system, I've been using them as a neuroradiologist for years. They have not yet been integrated in the clinical practice in breast imaging. For now, we have some limitations, just to let you know. They are technically demanding. They don't have any sort of standardization, and they use complex pharmacokinetic models for the breast. We don't have enough studies, and it's very difficult to make sense of the results. So we're going to get all these imaging markers in the end, and we're going to have a lot of information by gaining imaging markers, by quantitative imaging, but just with caution. The problem is to take a quantitative method and make it less quantitative if you don't know how to use it. So it needs a certain level of expertise. So here's a case from our institution where we had no change significant in size early in the course. However, the diffusion values did statistically change. So we know that this is a responder even early. The kinetic curves also changed before and after, during, and we knew that this was going to be a response way before the size, the shrinkage of the tumor. And this is another case where we had, again, monitoring during treatment, increase of the ADC values, again, indicative of response. Another case where we had a BRADS5 and a benign appearing lesion. The response was significant, MRI complete response confirmed by pathology, and we saw that also the benign lesion did show decrease in size. This is a case of large mass that we followed during treatment, a very good volume reduction, decrease in vascularity on our kinetics, increase in the ADC values, was responding. In the end, we reported as a good response, and the pathology came back also as a good response. And they did find scattered foci of tumor in areas of desmoplastic stroma, which we also found on the MRI enhancing lesion. Another case of HER2-enriched tumor, again, the kinetics showing the significant change, the diffusion values increasing significantly before. And here we performed a kurtosis. We measured for research purposes, again, our kurtosis value. And this is a diffusion technique. But just to show you, it's very interesting. You can actually present this as a graph and see before and during how impressively we had a decrease in this is a marker of heterogeneity of tumor.
Dr. Varaki, please, because we are running out of time.
Yeah, I'm almost done. It's
okay, thank you very much.
Sure. There was no residual enhancement, and this was a PCR. So future directions, because it's an innovative course, I think in every step, acquisition, measurement, and post-processing, we will be able to use imaging markers, such as the ones that I mentioned before, to map our tumor in a way that we can perform serial measures in vivo, we can perform parametric tumor mapping. This is the future, integrating what we call functional parametric imaging, using all the techniques and more to come. This also integrating artificial intelligence and radiomics in order to extract even more imaging markers. This will give us the opportunity to increase negative predictive value, possibly in the future to a point where we will not need biopsies to prove we're not there yet, and clinical outcomes. And it does have best accuracy, not yet, it cannot yet replace, of course, histologic diagnosis and surgery. An MRI complete response does not always correspond to pathologic response. And by combining the ability to perform MRI-guided biopsies, we could increase the negative predictive value. And remember that it can overestimate and underestimate in certain circumstances, and the future lies probably, as with everything, because we are the era of radiomics, omics, genomics, radiomics, in advanced multiparametric quantification techniques and the use of the omics methods. But, and I close with this to conclude, the most important thing that I think as a take-home message would be communication of the radiologists and the treatment specialists, to clearly and comprehensively present all of the information that I aforementioned, or all of this information that the MR has to offer will be lost in the images. Thank you very much.
Thank you very much for your excellent presentation. I'd like to welcome now our commentators, the oncologist, Dr. Barpunis, and the breast surgeon, Dr. Lanitis. I would like to ask you to keep the time, please. Δεν σας ακούω. Δεν ακούγεστε, νομίζω.
Microphone. Now it's okay.
Τώρα σας ακούμε.
Okay. Thank you for the invitation. Dr. Varakis, I enjoy very much your excellent talk. And from the clinician's point of view, I notice three major issues. One is the problem of false negative and false positive, and how we will eliminate these results. I think that it's not a major problem. but for the advances of MRI, I think that still is a problem. The second one is the measurement post neoadjuvant chemotherapy. This is a real problem for both the radiologists and clinicians, because we need desperately an information, and we may have it as accurate as we can. And finally, I think that artificial intelligence will give an answer, the correct answer, to both of these major issues, and radiomics will come in our everyday life and will help us to make some predictions regarding our patient, not only based on molecular signatures, but also to other information from the radiomics. These were my comments. Thank you for your talk.
I would like to comment just on Dr. Barbunis for the excellent questions. First of all, the negative predictive value of no imaging study at this point is below 10%, which would be needed to avoid any sort of biopsy, even in the breast or the axilla. It's higher, but MRI has the lowest negative predictive value of all the imaging modalities, at least the ones that are used in clinical practice. And the measurements, this is the most difficult part, and that's why I had to stress that MRI is so technical, and the way that we interpret the results is, even though it's an objective study, there is subjective interpretation, and that is a problem. However, if we're very cautious and we follow the guidelines, we can measure correctly or give a suspicion of areas which will help both the oncologist and the surgeon. And I stress additional biopsies it's used in the it's not used a lot in Greece, but additional biopsies or bracketing before surgery we're using at our institution. We're just before surgery. If the surgeon has a problem with an area, we're not sure, we say, you know, this is suspicious, we'll just either localize it or biopsy it. And that will increase our negative predictive value. We can do this, but we have to have centers that can perform these minimally invasive procedures. So
the list number of MRIs are 4.
What? Excuse me?
The minimal number of MRIs is 4 in case of neoadjuvant chemotherapy.
If you want to, the minimal is 2 before and after, but if you want to have an early prediction, for you, the oncologist, I would say at least 3, 1 early to just see if this is a response or not. Yeah, the surgeon may want before and after.
Okay.
Okay.
So I probably need the input from the surgeon point of view. First of all, I would like to congratulate for the excellent presentation. Obviously, cover the subject completely. There are a couple of issues. First of all, I'm going to start to the last slide, that the communication between the radiologist and the treatment specialist is very important. It's very important in the era of neoadjuvant chemotherapy, because lots of the information we're going to get for the tumor and for the extent of the tumor, they're going to be before the treatment. So it's very important to get an exact extent of the disease before the treatment. We need to know about the multifocality, the multicentricity, and about maybe tumors in the other breast before the treatment, because we're going to lose this information if the treatment is successful. So yes, we need to get a very good MRI, which is the best thing we have in our hands nowadays, before the treatment. The second step is the marker. Yes, we need markers. We need markers because most likely we're going to miss the tumor in the end of the treatment. So we need something to go back and remove something from that. That's something that we need to demand from the clinicians and from the oncologists and etc. Still, we're not very good, because if we were good, all the studies that before neoadjuvant chemotherapy estimation of the extent of the tumor, they're going to give us some solid evidence that MRI can predict exactly what we should do after during the operation. I mean, if it's going to be breast conserving surgery or it's going to be mastectomy. We know that we're not very good in predicting that, even with MRI, which is the best thing we have in our hands. The second thing is about the response to neoadjuvant chemotherapy. We still know that even if the MRI says that we have PCR, there are studies that we try to do, and we try to estimate the PCR by doing some biopsies in the air, et cetera, and we fail to prove that we may be able to avoid any surgery yet. So we are getting there, but we're not quite there yet. So I think we need a cooperation, we need communication, we need to do everything we could and we can to estimate before and after the size and the extent of the treatment. But we also need to be careful about interpreting the results and about deciding about the treatment, whether that's going to be before the neoadjuvant chemotherapy or after the neoadjuvant chemotherapy. About the extra foci, this is a problem, because if we have something in the other breast, for example, a small lesion on the other side that is 2 or 3 millimeters, and then disappears after that, and we haven't made a biopsy about that, is a medical legal issue maybe, because somebody's going to say you had a cancer there and you didn't biopsy it and you left it behind. So that's something we have to keep in mind. The better we become in identifying things, and the better we're becoming in the MRI and mammogram, etc., we're going to find more lesions. And maybe those lesions are without any clinical significance, but maybe with medical legal issues. I don't know, this is provocative what I'm saying now. And maybe Dr. Barbounis may have an answer about that, about this provocative thing that we may be having some medical legal issues about things that they're going to be showing the MRI, but we may not be able to do a biopsy on those.
Biopsy, biopsy, biopsy is the answer. So tissue is the issue of all question. If we have tissue, we answer to everything. So my clear-cut answer is take tissue when you are in a question.
Okay, thank you very much for your valuable comments. In conclusion, MRI, despite its limitations, remains the most accurate imaging method to help assess tumor response to neoadjuvant therapy and to plan surgery. We proceed now to the next presentation, and the president, Dr. Moudrea, which is a radiologist, head of breast imaging department at the Dinan Hospital. Please, Dr. Moudrea, proceed.